We could see the slide, Abhiram Lata.
Yes, ma'am. Thank you, ma'am. Good evening, everyone. So the next topic for the day is challenges in feeding late preterm neonates. So late preterm babies contribute to a large number of babies that we deal with day to day in our day-to-day practice, because the late preterm infants contribute to 65% of all preterm births, and they contribute to almost 10% of all the births. And data shows that there has been a significant increase in the number of late preterm births in the last 2 decades. Like how Kumudha ma'am said. So according to US data, there is a 25% increase, and according to Australian data, there is a 40% increase in the number of late preterm births in the last 2 decades. So the late preterm babies are the great dissemblers. Why we say like this is because they look like they are well babies, because they look almost like that of full-term neonates. So we tend to treat them as full-term neonates. But then they have a degree of immaturity that places them at higher risk of having poor short and long-term outcomes. So if we look at the short-term outcomes of late preterms, around 35% of them will need NICU admission, 12% of them will need respiratory support, 6% of them will need invasive mechanical ventilation, 20% of them will need IV fluids, and 16% will need phototherapy. So these numbers are definitely higher when we compare the same with that of term neonates. And even when we look at long-term outcomes, so the risk of neurodevelopmental disability and the risk of a child requiring special education is higher in late preterms when compared to term. So the late preterm babies are have twice the risk of having neurodevelopmental disability and 1.5 times the risk of requiring special education when we compare them with term neonates. And they are also at risk of metabolic complications like hypertension, diabetes, cardiovascular, and endocrine disorders as young adults. So most of the times we consider all these complications only for extreme preterm or very preterm neonates. So we should not forget that even late preterm babies are at higher risk of all these long-term adverse outcomes. So why nutritional management of late preterm neonates is important? Because if we look at the long-term growth, so these babies are at higher risk of being stunted or being underweight at 1 and 2 years of age. So when we compare them with term neonates, they are 3 times at higher risk of being stunted at 1 and 2 years or being underweight at 1 and 2 years. So on one side, nutritional management of these babies is important. On the other side, their nutritional management is more challenging. So if we have an extreme preterm neonate, we admit the baby in the NICU and we have a nurse to take care of the baby 24/7. So we have the luxury of managing the baby's nutrition and other management in the way we want. Whereas these late preterm neonates, they have to be managed in the postnatal wards. And apart from that, we do not have robust data on the incidence of morbidities. So we do not know what is the incidence of NEC or feed intolerance in these neonates. And the third most important thing is we do not have standard nutritional guidelines that are tailored to these neonates. So if we see all the nutritional guidelines like ESPGHAN or AAP guidelines, all those nutritional guidelines are meant only for very low birth weight or very preterm neonates. So we do not have separate nutritional guidelines for these late preterms. So because of this, most of our units have our own protocols for managing this. These are the admission criteria of three large NICUs in South India. So the admission criteria, criteria for admitting the baby in the NICU varies a lot. So some units tend to admit all babies who are less than 36 weeks or less than 2.25 kgs, whereas other units tend to admit only if the baby is less than 34 weeks or less than 1,800 grams. So the other thing is the feeding options. So there are 3 feeding options if we think of. So one is like we can keep the baby on exclusive breastfeeding. The second option is breastfeeding plus top up Sangha feeds with mother's own milk. And the third option is breastfeeding plus giving some other milk. So as Kumudha ma'am said, and as we all know that exclusive breastfeeding is the best for any baby, especially for preterm neonates. But these babies tend to have issues with breastfeeding. I mean, the incidence of breastfeeding issues in these babies is much more when we compare them with that of term neonates. So if we want to think if is only breastfeeding adequate, so they do have some physiological drawbacks. So the first major drawback is they have low glycogen stores. Because 50% of hepatic glycogen stores are laid down between 36 to 40 weeks of gestation. So because these babies miss this crucial period, they have lesser hepatic glycogen stores. And so they are at higher risk of developing hypoglycemia. The second major problem is their brain immaturity. So the brain weight of a baby at 34 weeks is only 2/3 as that of a term neonate. So only after 34 weeks, the gray matter and myelinated white matter increase exponentially to reach the term size by 40 weeks. So because their brain size is low, they have brain immaturity and they are at higher risk of developing feeding problems. So these are the ineffective breastfeeding behaviors that are demonstrated in late preterm neonates. So one is like they have weak suction pressures. So they cannot give strong suction like term neonates. And second is they have less muscle tone. So they have less postural tone. So they tend to slip off from the mother's nipple during feeding. And third is they have diffuse sleep-wake cycle. So their sleep-wake cycle is not robust as that of term neonates. So a term neonate, when the baby becomes hungry, the baby can wake up, cry for a feed, and maintain the wakeful state until the baby finishes the feed. But this doesn't happen in late preterms. So these babies tend to fall asleep early in feed. So their breastfeeding becomes less effective. And last but not the least, they may have poorer coordination of suck, swallow, breathing reflexes, which can predispose them to cardiorespiratory instability. So the other major problem in this group is the mothers of late preterm infants are at risk of impaired or delayed lactogenesis 2. So we know that lactogenesis 2 is something which is triggered by withdrawal of progesterone. So this is the one that transitioned the mother from just 15 to 20 ml of colostrum on day 1 to 500 to 600 ml of milk by day 4 to 7. So during this period, that is the first week of postpartum period, the number of secretory cells in the mammary glands increase and the density of prolactin receptors in the mammary epithelial cells increase. So all these physiological changes contribute to the onset of lactogenesis 2. Though withdrawal of progesterone is a major factor, so this step is catalyzed by a unique human infant sucking rate and rhythm. So that is, I mean to say that these early days is very critical for the mammary gland. So the mammary gland must receive the timely and appropriate stimulation from the infant. So infant's sucking is a very important stimulus for this lactogenesis 2 to set in properly. So unfortunately, these late preterm infants have immature sucking behavior. So they may not be able to give adequate stimulus to the mammary gland. So this increases the risk of delayed or impaired lactogenesis 2. On the other hand, the mother is also having so many risk factors. So preterm delivery per se is a risk factor for impaired lactogenesis 2. And apart from that, the other risk factors are diabetes, PAH, cesarean delivery, high body mass index in the mother, prolonged bed rest, and other intrapartum complications. And if we think most of the mothers who deliver late preterm have one or more factors. So on one side, we have the baby with immature physiology who has poor psych and immature suction pressures. And on the other side, we have the mother who is also having risk factors for poor lactation. So both these together result in delayed or impaired lactogenesis 2, so which results in less milk production in the mother and lower rates of exclusive breastfeeding to the baby. And the baby also develops lactation-related morbidities. So how are we going to support breastfeeding in these neonates? So we have two major objectives when we want to sustain breastfeeding in late preterm infants. On one side, we have to ensure that the infant is adequately nourished. And on the other hand, we have to protect the maternal milk supply. So we have to do both. Then only we can sustain breastfeeding in these neonates. So how are we going to support breastfeeding? So two things that we can do to facilitate milk intake during breastfeeding are properly positioning the baby and sometimes by using a nipple shield. So we already said that the late preterm infants are hypotonic. They do not have adequate postural tone, especially the flexor tone. So they may not be able to maintain the head and neck position during feeding. So adequate support of the head and neck during the breastfeeding period helps them to suck better, suck in a more effective way at the breast. And the second thing is swaddling. So swaddling the baby again helps to maintain the postural tone and it helps to maintain the flexed posture of the baby, so which in turn results in better feeding behavior. So adequately supporting the head and neck and swaddling the baby, these two aspects will help in better milk transfer during breastfeeding in these neonates. The second thing is the nipple shield. So because these babies do not have strong suction, so they may not be able to create the nipple shape during feeding. So if we use a nipple shield, that creates a nipple shape so that strong suction pressure is not necessary. And once we latch the infant to the nipple shield, the suction created by the infant creates negative pressure within the tunnel of the shield and it facilitates milk transfer. So there are studies to show that if we use nipple shield in late preterm neonates, they are able to breastfeed in a better way. So how are we going to assess breastfeeding in these neonates? We know that there are a lot of tools to assess breastfeeding. So one of the best studied tools is this Bristol breastfeeding assessment tool. So where we assess the breastfeeding based on 4 components, namely positioning, attachment, sucking, and swallowing. The second aspect is protecting the maternal milk supply. So we already said that these late preterm neonates do not give adequate stimulus to the mammary gland. So what we can do is we can use a hospital grade electric pump to provide the same stimulus to the mammary gland. Again, there are studies to show that if mothers who use breast pumps during the first week of life are able to have better and more sustained breast milk production than those who did not use breast pumps. Okay, so after taking all these efforts, we can try to maintain the baby on exclusive breastfeeding. But then if the baby doesn't take, if exclusive breastfeeding is not adequate, then the second best option is to give breastfeeding plus top of Sangha feeds with mother's own milk. So topping up with express breast milk. So what the guidelines and the experts say is it's better not to give each feed as direct breastfeed plus Sangha feeds. So because when we try to do this, on one side, the mother gets exhausted. And secondly, the duration of each feed increases a lot. And third, whenever we want to give both direct breastfeeding and Sangha feed to a baby, then mother will tend to concentrate more on the Sangha feed than on the DBF. Because Sangha feed is something which she is seeing objectively. So she can, she can measure how much milk the baby is taking. So mother will tend to stop breastfeeding, direct breastfeeding earlier and try to resort to Sangha feeds earlier. So that will affect the direct breastfeeding duration. So the better options are to give alternate direct feeding and Sangha feeds. So that is one feed DBF and next feed Sangha feeds with EBM. So in this way, the direct breastfeeding duration will not be affected, and mother also will get adequate stimulus for her mammary gland. And or alternatively, we can even have periods of DBF and periods of EBM. That is morning hours DBF or night hours DBM. Like that also we can do, so that we ensure specific quantity of milk intake to the baby for in a 24 hours period. So the other way of checking whether DBF is going on well is test weighing. So test weighing is not really practical at home in our community. Maybe when the baby is in the NIC or in the postnatal ward, we can do this. So this is nothing but weighing the baby before and after a feed. So the number of grams of increase after a feed is roughly equal to the ml of milk taken by the baby. So for this, we need a much more precise weighing machine to the nearest 1 gram or 2 gram, or at least to the nearest 5 gram. So for example, if there is a 30 gram increase, then we can say that the baby has taken 30 ml of milk from the direct breastfeeding. So whenever we start a baby on direct breastfeeding plus Sangha feeds with EBM, then the transition towards changing the baby to only direct breastfeeding should happen over a few weeks. So we should not be in a hurry to resort to only direct breastfeeding. So this is taken from one of the studies that showed that in the first week of life, the amount of breast milk taken by the baby from DBF is less, but then as the weeks increases, the proportion of milk taken from DBF is increasing. So basically, we can try to get the baby on 1D DBF when the baby reaches term corrected age. So if neither of these two work, that is neither the exclusive breastfeeding nor breastfeeding plus top-up EBM work, then only we have to go to the third and the least preferred option of giving breastfeeds along with some other milk to the baby. So this is done only if breast milk is inadequate despite all our efforts. And if we want to do this, then the choices are obviously the best choice is pasteurized donor human milk, but then unfortunately, PDHM is not accessible or affordable for most of our babies because milk banks are not available in all the centers, and the commercially available PDHM is quite expensive. So the only option we are left with is formula feeds. So whenever we start formula feeds for late preterm infants, we have to understand that they are also at risk of NEC. So the incidence of NEC in late preterm infants is 0.5 to 4 per 1,000 live births. But then if we have no other option, then sometimes we resort to formula feeds. And then the next question is which formula we have to use, whether we have to use a preterm formula or a term formula. So for this, first of all, we should know the nutritional requirements of late preterm neonates. So as I already said, we do not have separate guidelines for late preterm infants. So this is an article where the author discusses the nutritional requirement of late preterm infants. And these are just extrapolated data from that of extreme preterm and term neonates. So if we see the target weight gain of late preterm infants, their target weight gain is around 13 gram per kg per day, which is in between an extreme preterm and a term neonate. And the protein requirement is 3 gram per kg per day, which is again in between an extreme preterm and a term neonate. So apart from these, the calorie requirement, minerals and vitamin requirements of late preterm neonates are almost equal to that of an extreme preterm or a very preterm neonate. So if we look at this data, then we may feel that a preterm formula may be a better choice for these late preterm neonates. But then we do not have robust studies, RCTs or something to prove which is better. So as of now, we are going by weight. So what we do practically is, if a baby is less than 2 kgs, we start the baby on preterm formula. And if the baby is more than 2 kgs, then we start the baby on term formula. And this is mostly based on manufacturers' recommendations. So what about other supplements? The American Academy of Pediatrics recommends that all preterm infants, including late preterm infants, should receive multivitamin and iron supplements until the baby receives diverse complementary diet. And additional calcium and phosphorus, mostly we don't give for late preterm infants. But then when we look at their requirements are same as that of an extreme preterm infant. And these infants miss almost half of the third trimester. So the third trimester is the period when the calcium and phosphorus accretion from the mother to the infant takes place. So because these babies miss half of the third trimester, they may have lower calcium and phosphorus stores. So they may be at higher risk of having these mineral deficiencies. And third is the human milk fortifier. So we don't use a HMF in late preterm infants because none of the guidelines recommend us to use the same. We use it only rarely when the baby is not gaining weight on direct breastfeeding and EVM, then we sometimes rarely use human milk fortifiers. So these are the three options for feeding in these neonates. So I just want to discuss three small case scenarios. So case one is our ideal scenario where a baby is born at 36 weeks of gestation with a weight of 2,200 grams. The baby was born by vaginal delivery to a G2P1 mother who has exclusively breastfed the previous baby. So basically, other than being a late preterm, the baby mother-infant diet does not have any other risk factor for breastfeeding failure. So this baby was observed in the delivery room for 6 hours. Baby was found to be stable. So baby was given 2 direct breastfeedings under supervision. So basically, the feeds were assisted by a trained nurse, and who found that the baby is taking direct breastfeeds well. Baby sugars were normal, so baby was shifted to postnatal ward. So in the postnatal ward, again, DBF was ensured. The baby was taking direct breastfeeds well. Again, sugars were normal. Weight loss was within normal limits. Baby did not have significant jaundice. So the baby was discharged at 72 hours. And this baby was followed up at 1 week, 2 weeks, and 4 weeks. Baby was found to be feeding well and gaining weight. So this is almost like that of a term neonate, but then we had to have some extra vigilance. Then coming to case 2, so this is baby B, born at 34 weeks with a weight of 1,900 grams. The baby was born by LSCS due to maternal PIH to a primary mother. So baby had transient tachypnea of newborn, so had to be kept in the NICU for 48 hours. During that time, baby was given orogastric feeds with formula. On day 3 of life, baby was initiated on direct breastfeeds when the tachypnea settled. So, but baby was found. It was found that the baby was not sucking well. So positioning and attachment was taught to the mother. So at the same time, mother was also taught how to express milk by using a mechanical breast pump. So mother was taught to give Sangu feeds to the baby. So both the baby was discharged on direct breastfeeds and Sangu feeds when the mother became confident by day 5. So baby was discharged in alternate direct feeds and Sangu feeds. And baby was followed up at 1 week, 2 weeks, and 4 weeks. And the Sangu feeds were gradually reduced. So and baby was transitioned to exclusive direct breastfeeding by 38 weeks. And after 38 weeks, further follow-up showed that the baby was gaining weight only direct breastfeeds. So in this baby, though we had some itches initially, baby picked up nicely and reached the stage of getting nutrition only by direct breastfeeding by term gestation. Then coming to case 3, so this is a baby C born at 35 weeks with a birth weight of 2,300 grams, vaginal delivery, primary mother. Baby was stable, started on direct breastfeeding at birth, and discharged on day 2 of life due to parental request. So on review at day 5, baby was found to have a 17% weight loss. Baby also had hypernatremia, oliguria, and significant jaundice. The baby was managed with phototherapy and fluids. On breastfeeding assessment, the healthcare workers found that the baby was not attaching well, and mother's milk secretion was also less. So baby was started on formula feeds transiently, and mother was started on lactobox. And the positioning attachment was taught to the mother. And this mother-infant diet required 5 days of hospital stay to re-establish breastfeeding. So this whole readmission and the morbidities could have been avoided if we had kept this baby for one more day and assessed breastfeeding and made sure that baby was feeding well before we could discharge the baby. So I want to finish off saying that adequate vigilance is the key. So though these late preterm infants can be managed like that of term units, we just have to take certain extra measures. So if we want to shift the baby to the mother side soon after birth, it is essential that we have a 4 to 6 hours observational period in the delivery room itself. So during this period, we have to make sure that the baby is maintaining temperature, baby does not have any respiratory distress, and the baby is maintaining saturation, and baby is taking direct breastfeeds well. This should be assessed by a trained nurse, and blood sugars should be normal. And even after shifting to postnatal ward, we have to a trained nurse has to assess at least 2 feeds per day for the first 2 days. So this will help in both assessment and assistance, so that the mother becomes confident of giving direct breastfeeds. And sugar monitoring for 48 to 72 hours is essential, and we have to make sure that the sugars are normal. And daily weight check, we have to make sure that the baby is not losing weight more than 2 to 3% of birth weight every day. And the discharge. So discharge is one major factor, especially because of many of the parents' financial situations. They want to have early discharges. But AAP specifically recommends that late preterm infants should not be discharged at less than 48 hours. So AAP recommends, AAP guidelines state that discharge at less than 48 hours is only for term units and not for late preterms. In late preterms, early discharge itself is defined as discharging on day 3 to 5. And that is done only after ensuring that all is well. And the lower the gestation age, the later should be the discharge. And after discharge also, again, we have to have a weekly or at least a bi-weekly review until the baby becomes term to make sure that the feeding is going on well and the baby is gaining adequate weight. So if we are ready to take all these vigilance measures, we can manage the baby, manage late preterm infants like that of term infants, and we can discharge them on exclusive breastfeeding. Thank you.
Thank you, Dr. Abhiramalata, to bring out all the problems late preterm actually undergoes and the type of nutritional support or the breastfeeding support we have to give. I have few comments. Before that, I think there is a question from the person in the chat box. 1 minute. What is a remedy for mother with inverted nipple other than formula fed initial?
Yeah, so inverted nipple is one major problem. So the problem with inverted nipple is more than the mother, the nurses get very much, dissatisfied if a mother has inverted nipple. So we know that a nipple is not a major problem for feeding because the baby has to latch on to the areola. So, but then to initially latch, maybe the baby may need the nipple. So mostly, if it is only a flat nipple, then just finger stimulation itself may bring out the nipple in many mothers. So just stimulating the nipple, rolling out the nipple with fingers itself might help. But then if the mother has very much inverted nipple, then we may have to use a nipple puller or sometimes an artificial nipple, like how I showed. So previously we were using the syringe technique, but the syringe is very crude. Sometimes if the mother pulls out very, very fast or very vigorously, she may develop a cracked nipple and the nipple may start bleeding. So these nipple pullers are available now in many brands. So it is like a bulb sucker that we used to use previously for suction, oral suction during deliveries. So that will give a little less pressure and it may be less traumatizing to the nipple. So we can use a nipple puller. And if that is also not working, then many mothers nowadays are comfortable with using a nipple shield. So we can try that as well.
Okay, Dr. Abhiramalata, I have a few comments on your talk. One is for breastfeeding a late preterm, we need definitely one person to initiate feeding in the labor room, not just give the mother for feeding and expect her to feed on her own because the child has a handicap and the mother has a handicap. And number two is maybe in the first few days, hand expression would be better because that brings out much more milk than breast pumps, because especially if she's 34 to 37, when you use a hospital grade pump, she may get 1 or 2 drops which she looks at the bottom of the bottle and gets very dissatisfied. So that will be another thing.